So the next moderator for our upcoming panel is actually the person who really envisioned this survivorship symposium that we're living out today, Dr. Cherie-Ann Nathan. She's been a longtime board member of the Head and Neck Cancer Alliance, has been very active not only in this organization, but also in the American Head and Neck Society, which is our main professional organization. She served as a president of that group and really served to highlight the importance of survivorship and the quality of life after cancer treatment to many of us. She'll be now starting an afternoon session on the importance of the impact of oncology rehabilitation in head and neck cancer patients and survivors. So Dr. Nathan and the panelists, please come on up.
So good afternoon, everyone, and we wait for Hannah. There she goes. Thank you, Mike, for that introduction. It's so lovely to see so much engagement, and I've been in practice for almost 28, 29 years, and we were just talking over lunch. I mean, so many years later, you see patients coming back with delayed effects of chemoradiation, silent aspiration, osteoradionecrosis, carotid artery, and you realize that it's constant. You've just got to, it's a team sport, like Joel said. You've got to start rehab before, during treatment, continue what you're doing even after treatment. So I'm honored to moderate this panel, and really want to welcome you all after lunch, and hopefully you will wake up again with some of the stretching exercises later. But I'm a professor and chair at LSU Health and director of the Head and Neck Feist-Weiller Cancer Center there. I want to thank our panelists for joining us today, and we're really going to emphasize the importance of rehab for head and neck cancer patients and survivors. I think the session is going to offer a team of not just healthcare professionals like myself, the surgeon, but our speech-language pathologist, and two survivors who are going to highlight the benefits and the role of oncology rehabilitation. As with all sessions, we'll have our question and answer session at the end, as well as our remote audience at the end of the presentation. So we're going to start with our first speaker, Hannah Wu, who in 2003, when she was a graduate student, was diagnosed with nasopharyngeal cancer. And she underwent, a combination of 43 chemotherapy and radiation treatments. And for decades, Hannah has benefited from physical therapy for her sore and stiff neck muscles. And in 2021, Hannah began oncology rehab for other long-term side effects that she's been experiencing. So, Hannah, if you will come up and share your experience.
All right. Will this work? Use my lapel? Or should I use?
Yeah, I think.
Should I use my lapel, or is that okay? Okay. All right. Let me get my little timer here going, because I could be talking all day here. All right, well, hi everybody, I'm Hannah Wu. I'm half Chinese, and it really plays a little bit into what we're going to talk about today, because I did have nasopharyngeal cancer, which is 1% of all the cancers in the US, but 28% of all the cancers that they have in Southeast Asia. So there's a lot of cancers in Asia, but not very many here. So the doctors were really confused about if I even had cancer, because people who are 25 usually don't get cancer actually anywhere really, but especially that kind of cancer. So it was 2003 when I had my cancer, and I was 25 years old, and I kind of feel like a dinosaur standing up here, because a lot of people were like, I had the old radiation, like the one that they showed up earlier, and they were like, oh, there's the old kind, right, where they shoot it through, and there's a new IMRT, and I was kind of jealous, because I was like, why couldn't I get that, you know? That was the kind where they shot it like exactly, you know, where your cancer was. And they said to me, Dr. Yam earlier was like, I can't remember when we had that. Well, you know, it was 2003, Dr. Yam, because they told me I could go to San Francisco and do it. And I couldn't go to San Francisco because my cancer was too far advanced. It was about this close to hitting my brainstem. And they were like, you can go to San Francisco and, not have all these side effects. And I was like, well, I can't because it's going too fast. And I didn't know the side effects were that bad. And I was like, well, I'll just do it here, you know. And I didn't know I was going to have to do anything later. I thought when I was cured, they were like, you're cured. I was like, oh, 6 months and I'm out. I was like, wow, this is amazing. But it was a really hard treatment. So every cancer, it depends on how hard your treatment was, right? My treatment was really hard. It was 40 treatments of radiation while I was doing 3 treatments of 6-hour cisplatin during that treatment. Then after the treatment, I had 6 treatments in the hospital, 3 treatments in the hospital of 6 days, continuous infusion. Cisplatin, 5-FU, 6 days, 1 day off. Then you have the next 6 days. Then you have a few days off, actually. Then you have 6 days, continuous infusion, cisplatin, 5-FU, a few days off. Then you have 6 days, continuous infusion, 5-FU, cisplatin. And then I was cured in 6 months. So for 17 years, I thought I was fine. I was cured, I was living my life. Sometimes I wonder if it was better because I didn't know what was coming, you know? But actually, maybe it was not better, because then I wouldn't have 2 carotid arteries that one is 100% blocked, one is, 50% open, which with medication helped, which was great. But I have 4 stents, you know. I have a feeding tube, a G-tube. I have no saliva glands, no thyroid gland. I have I don't know. I just have a lot of problems, But I'm doing pretty good, I have this person who helped me a lot. I saw her after, I've been going to a speech therapist for 2 years, so I don't think I'll need you anymore, but they said I should keep on going, so I'm gonna try, okay? And she was like, okay, let's just go to one more and see if maybe I can help you still. I came out and I was like, I think we can do a few more meetings. But this is what happened to me. I actually didn't know that I had to go to follow-up. And one day I was at a Las Vegas buffet, and I choked in front of everyone. And they were like, what's going on? I was like, I don't know. I just can't swallow anymore that well. And also, another time, I went to my PCP 17 years later, and I was like, one doctor says I have a heart murmur, and the other one says no. I go again. They say, you have a heart murmur. No, you don't. Do I have a heart murmur? He's like, hold on, be quiet. He listened to my carotid, and he goes, we're going to do an ultrasound. I said, oh, okay. So when all this stuff started happening, I couldn't work anymore. So, because I was too busy going to the doctor. It was my full-time job to go to the doctor. And what I found out is there are problems of radiation, and it happens later. And it happens 17, 15, 20 years later. And what happens is when the radiation starts messing up your body, it starts building up. It starts harming. It was harming the inside of your veins for so long, and then pretty much it acts like basically it's damaged inside, and pretty soon things start sticking and attaching to the inside of your carotid, and pretty soon you're going to have a stent there or be on some, atorvastatin, to stop the buildup of cholesterol that maybe you don't even have a cholesterol problem, but you're going to have one pretty soon because of radiation. So I've been an academic my entire life. I have my master's degree. I basically made it my PhD to go ahead and make it in learning about nasopharyngeal and late-term effects. And I learned so much. PubMed, of course, nothing, no internet, Wikipedia or anything. Don't worry. I taught on a college campus for a lot of years. I learned all about it, and I learned all about my xerostoma, my osteoradionecrosis. I learned all about all of that, and I think it saved my life. I became a full-fledged EMT, and I caught my stroke before it happened. As soon as it happened, I was like, crap, left side seizing up. I'm having a stroke, crap. Call ma, because that was my mom visiting at the time. And I had a brainstem stroke, you know, and I lost all of my ability to walk or even use my hand, and now I can almost run. You know, it's amazing. Well, unfortunately, the radiation also knocked out my baroreceptor, so it has a problem regulating my my blood pressure. So I had some seizures a while ago, but now I take my my blood pressure all the time, and I got through that too. And the last thing I wanted to kind of mention was mental health. After all the seizure stroke stuff, you know, you get 40 treatment radiation to your head, your brain, right? Oh, come on, you got to have a psychologist and a psychiatrist following up with you through this whole thing, okay? Because sometimes when you cure the depression, anxiety, and ADHD that you're going to get from all this, sometimes you, that's my reminder, stop talking. When you get a psychiatrist and psychologist to help you with your brain stuff, sometimes you feel like walking more, and that's going to help your cardiovascular, it's going to help you get out of bed, it's going to help you stop thinking I'm so mad. Maybe if you get past anger, you can get to the depression, and you can feel better in general. And I just think you should make sure that's part of your whole thing, you know, is having a psychologist, a psychiatrist. And the last thing I want to tell all the survivors is, don't worry about everybody else. Worry about yourself. And I think if you worry about yourself, it's very likely that the cancer is not going to come back, because you got to worry about your own self and living. Don't worry about everyone else. They're worried about you. And I also tell the caregivers, don't worry about them. They're the ones on the Oxycontin, okay? You're not on it, okay? They're doing okay. Okay, they're going to get off of it too, don't worry. Okay. But all I have to say is this. If you're going to be a survivor, care about yourself. You're going to get better. It's going to be okay. As soon as you get further past out that 5-year mark, you're going to be all right. And you know what? You're going to be okay with the uncertainty, because all you got to do is just get through the next thing. Through the next thing. It's just like sports. Get through the next thing, okay? Thank you.
Wow. That was quite a story, journey, and so inspirational. Thank you, Hannah. So we now have Julia Porter, who is a speech-language pathologist and team lead oncology rehab at IU Health North Hospital, IU Health Schwarz Cancer Center in Carmel, Indiana. Julia is also a survivor of adenoid cystic carcinoma and a Head and Neck Cancer Alliance ambassador. Thank you, Julia.
Okay, oh, yeah, there we go, we're live. Hi, my name is Julia Porter. Like Dr. Nathan said, I'm a speech pathologist at IU Health North, Joe and Shelley Schwarz Cancer Center. And today I'm going to be speaking with you about the importance and impact of oncology rehabilitation from diagnosis to through surveillance. And I think our panelists here really kind of represent that continuum. You just heard from Hannah, who was diagnosed decades ago, kind of before our treatment methods, but also our supportive care services were really what they are today, and we still have room to improve in that regard, but really kind of a bookend there, I think. Okay. There we go, okay. I was about to say next slide, but I don't, okay. So you may have heard the phrase, you know, a call to action before. I feel like that phrase kind of invokes the concept of there's a problem that maybe we didn't know was coming, and then now that it's here, we can't ignore it any longer. And if you've been a speech pathologist in the head and neck world for any time, you've probably heard this phrase referred to, I think Dr. Kate Hutchison was the one to kind of coin it, as we recognize the impact of swallowing long-term on our head and neck survivors. You know, we need to do something about that, recognize it sooner, address it sooner. And I think this is starting to be kind of on everyone's lips when it comes to survivorship and oncology rehab, kind of that larger umbrella of oncology rehab. And so here's some of the reasons why that call to action is really important. we know that the face of head and neck cancer is changing. Survivors are being diagnosed at younger ages, partly due to the rise in HPV-mediated oropharyngeal cancer. Screening tools are better, awareness is improving, and then also we have patients who are being cured at higher rates. And all of this means that you have more people living more years of life with potentially devastating side effects of their treatment. Some of these common toxicities, like we were talking about today, can be trouble swallowing, fatigue, pain, shoulder and neck dysfunction, posture changes, mental health effects, and essentially a lot of these things can result in patients regretting ever treating their cancer in the first place, which is a really sobering thought to think that, we've cured this cancer, but at what cost? So some of the common treatment modalities such as surgery, radiation, and chemotherapy can have both local and systemic effects on the body. So surgery can affect shoulder function. We can have radiation, as we've kind of really dove into today. Chemotherapy, which I don't know if we've talked about enough today. Some of that chemo-induced peripheral neuropathy, cognitive changes, balance issues. And really, any or all three of these, and in any order that they're received, can have a major effect on a survivor's ability to live, work, and play in their home and community environments. So I'm going to highlight some of these specific things. So a common reported symptom includes both pain and fatigue. It's important to note that cancer-related fatigue kind of goes beyond your usual tiredness. It's really thought to be kind of this persistent, pervasive exhaustion that is thought to be related to really directly to the cancer and the cancer treatment itself. There aren't really a lot of good longitudinal studies specific to head and neck cancer and radiation, but some can report even moderate to severe fatigue rate of 18% of survivors even over a year after diagnosis. And so I think a lot of people hear that kind of 1 year benchmark, or I hear patients tell me that they think give it a year. It's important to know that some of these things can really persist after that, and some of that tiredness may not be just normal tiredness. Pain or underlying pain mechanisms in head and neck cancer survivors can be different from that than the general kind of population as well. And so some of these kind of traditional first-line treatment methods may not be appropriate either for our head and neck cancer survivors. And so kind of these two things together or separately can really kind of impact that survivor who's trying to get back to work or get back to caring for their kids or their parents. And these two things can really get in the way of doing that. We've talked a lot about radiation fibrosis today, but I do like this image from Dr. Stepplefield's Oncology Rehab textbook. I show this a lot to patients because I feel like it really kind of highlights the difference between normal tissue and tissue that's been exposed to radiation and that buildup of fibrin or scar tissue, as it's also been referred to. And I often talk to patients about how this can really affect all layers of tissue, from subcutaneous tissue to the muscle, to the nerves, arteries, lymphatic supply, the muscles. And so it really shapes kind of, as an oncology rehab professional, how I'm treating and understanding that underlying pathophysiology behind the radiation really drives what I do in treatment as well. We talked about lymphedema today as well, and I think Dr. Starmer mentioned earlier how that lymphedema isn't always necessarily external or visible. And so obviously on the left you have that clear kind of facial edema, but then some edemas or lymphedema or lymphatic dysfunction changes are best viewed endoscopically or sometimes in routine surveillance imaging. And so that second image there being an endoscopic view of the larynx, you can really see those tissue changes as compared to the kind of normal larynx on the right. And so another view here kind of showing that a different view of lymphedema on a popular test known as a modified barium swallow study. We can really see these internal structure and external changes when we're assessing function through these tests. So what can we do about this? We've talked a lot today about early intervention. Clinicians can dramatically affect or impact adverse long-term functions or outcomes by maximizing preventative measures and post-treatment rehabilitation. As we've recognized these chronic issues and their negative impact on survivorship, emphasis has been increasingly placed on the importance of early oncology rehabilitation. Ideally, we are thinking about and planning for long-term functional impact at the time of diagnosis and as we're making the cancer treatment plan itself. And in some cases, even a good assessment of physical function and status can change the treatment plan, and sometimes that's a good thing. And so, again, we really want to be getting into those services, supportive care services, rehabilitation services, and start thinking about what survivorship looks like, because it really does truly begin at the time of diagnosis. So as a patient begins cancer treatment, or even before they start, they could benefit from any or all of the areas of focus. Swallowing therapy can include proactive swallowing rehabilitation or swallowing therapy, which we talked about today, monitoring for trismus or kind of proactively assessing for that. We have good research to support that those who engage in this tend to have better long-term outcomes when it comes to swallowing and reliance on feeding tubes. Lymphedema, as we talked about, is often under-recognized need. I think people in this room all recognize it as a need, but maybe outside of here, I think it's less recognized in the general public. And so high-quality lymphedema therapy can be really provided by any rehabilitation therapist that has the adequate training. So that can be a speech pathologist. I am a certified lymphedema therapist, can be a physical therapist, an occupational therapist. But this therapy should include manual lymphatic drainage, compression, low-intensity exercise, and stretching. And then obviously our PT and OT friends can be utilized earlier on in treatment than they often are. This can include working on cervical range of motion, again, that shoulder dysfunction that can happen after surgeries, scar management from neck dissections and flaps, treating neuropathy, working on strength and balance. And while awareness for early, at least swallowing therapy is something that is recognized by the NCCN, really the referral rates for all three disciplines can still be fairly low. A 2019 analysis of Medicare patients, over 16,000 head and neck survivors, Medicare patients, an analysis of that found a utilization of rehab services, a rate of 20% for speech and 26% for PT and OT. This was for patients treated between 2002 and 2011, so I would hope that that number is much better now, but I do think that patients still can fall through the cracks. Some common professionals that work in this space, as I mentioned earlier, physical therapy, occupational therapy, and also PTAs and COTAs, speech-language pathologists, exercise physiologists, and also our PM&R colleagues, or physical medicine and rehabilitation physicians. These are medical doctors who have a primary focus on improving a person's function and can be really crucial to your oncology rehab team. We know that physical activity for cancer patients and survivors is safe, feasible, and beneficial. I think the American Cancer Society recommends like 150 to 300 minutes of moderate intensity exercise a week. We're still learning more about, specifically related to head and neck cancer, what types of exercise could be beneficial, such as like progressive resistance training. But often the case is that patients can go into cancer treatment already at kind of a low level of activity, which then decreases during cancer treatment and then never quite gets up to that pre-treatment baseline, which can already be low. So I talked a lot about early identification and how that's really important, but there's many of you here in the room who are years out from your treatment, and what's out there for me. That window of opportunity was kind of missed. We didn't know what we were dealing with. What can I do? These head and neck cancer patients in general, and then especially our long-term survivors, really need a cross-systems approach to therapy, meaning that we are working on multiple body systems. For lymphedema, we're doing complete decongestive therapy, more hands-on things for fibrosis, respiratory muscle strength training, breathing and swallowing training. There's a little bit coming out about that. Skill-based training. So it's not all necessarily strength. A lot of times that fibrosis is that stiffening and induration of crucial structures, and so your kind of traditional exercises may not be beneficial for that. And often this kind of highlights the importance of our oncology rehab team working closely with additional specialists, potentially like physical medicine and rehab and laryngology for some of these kind of optimization procedures, if eligible, to help augment your therapy. So, for example, esophageal dilation. I've had patients who have had that in the past one time and it didn't do anything. Often that needs to be done more than once, or the timing needs to be changed. Let's go ahead and try it again and then get you in for some really intensive therapy right after in kind of that nice window of opportunity. And so there are different kind of, some more controversial than other adjunct treatments out there as well. This is just some examples of those. These are ultimately just tools. What's important is the clinician who's using them and applying them, and then also really understanding the patient that you're working with and the underlying factors to their impairments. We know that early intervention is best, but that late is better than never. And newly diagnosed patients who really are healthcare consumers, they're not going to be asking where the best radiation machine is or where the best cisplatin dose is. They're going to be asking what cancer center has the services that I need to support me to get back to what matters most to me, which is often not being in your office, but out enjoying time with friends and family. And oncology rehabilitation is increasingly important to that endeavor. And that is it. I had a reference page. There it is. Thank you.
Thank you, Julia. That was such a nice, thorough review of all the long-term complications and what we can do to help our patients. So our final panelist, Mark Laughlin, is a survivor of oropharyngeal cancer and currently lives in Anderson, Indiana. In 2022, mere 6 weeks after his mother lost her 4-year battle with cancer, Mark received his head and neck cancer diagnosis. Following his treatments, Mark applied the discipline he acquired as a football player, and he embraced and dedicated himself to the neck and mouth exercises his therapists prescribe, knowing it would only benefit and assist in his recovery. So Mark, please share your story with us.
Thank you. Well, just about a year ago, actually Halloween, October 31st, 2022, I was diagnosed with cancer. About 3 weeks later, I had surgery. Dr. Moore, he tore me up. We were in there about 9.5 hours, and I was bruised from here down, the whole chest and everything, but I wouldn't change a thing. The guy knew what he was doing. So went through that surgery, started radiation and chemo first of the year. Went 5 days a week for radiation. I think there was 38 sessions, something like that. And then I had chemo once a week for that time period as well. So 5 days a week of radiation, 1 day a week of chemo. I refer to everything. I played sports my whole life, coached high school football for 14 years, coached travel girls softball for 14 years. In fact, today, first day, my daughter's playing college ball, her first game. I don't get to see because I'm here with you folks. But I wouldn't change it any other way. I will tell you this and I'll move on, but her first at bat as a college player, she got a hit. So that's all that matters. We've kind of worked that way the whole time. Dr. Nathan kind of set me up on this. She said that this is a team sport. I totally agree. So I kind of break it down this way. I got my head coach. That's Dr. Moore. He comes up with the game plan, puts it all together. Here's how we got to attack this. Then I had Dr. Jensen, which was my radiation doctor, and he's kind of like the line coach. He's got to dial in where we've got to attack. So we're going to attack this hole, and we're going to run the ball right up that hole. So he plans that out where we're going to attack with that radiation. Then there's the team mom. That was Dr. Rashaw. She was always worried, let's test this. I better get with Dr. Moore. I don't know if that's healing right. So, you got to make sure you're eating right. We're going to have to put a feeding tube in you. You're losing too much weight. And I think I used to frustrate the team mom. I used to tell her, she would tell me every time, she said, we're going to put that feeding. I said, you're not putting a feeding tube in me. I'm going without it. I got plenty of weight to lose. I'm good. And but the one thing I'd always tell her, I said, do you ever watch Naked and Afraid? She'd look at me and I'd say, they could eat a fly and live for a week. So finally, the last meeting I had with Dr. Rashaw, she said, Mark, I'm really worried. You sure we might have to put this feeding tube in? And I started to talk. She said, I know, Naked and Afraid. She finally got it. So there's a great team that goes together. So that's my coaches, right? And the team mom. But key to this whole team was let's call it the athletic trainers. That's our physical therapist, our speech therapist, our occupational therapist. Those ones that really help us get through everything. Without them, I probably couldn't eat, probably couldn't talk, whatever, a lot of things. My shoulder, he's cut down into my arm. He really tore me up. I thought we were operating up here. He ended up down here. So, But anyhow, he done that. He grafted muscle on the side of my carotid artery to help protect that. But the key to this is our athletic trainers, our physical therapists, our occupational therapists. You see them once a week, once every 2 weeks, once a month. Still really not going to do anything for you. You've got to work outside the game. If you want to get better, you've got to work outside the game. A lot of us would say we don't have time. I don't have time to work on those mouth exercises. I get home at night and I'm tired. Well, I can tell you this, I hit 465 over on the east side of Indy every morning, probably between 5:30 a.m. and 6 a.m. I see a lot of the same cars at that same time. And they're probably thinking, here comes that idiot in that white Traverse. And you're probably thinking, well, I'm in the car, I'm going down the road, and I'm doing my mouth exercises. They're probably thinking, that guy's in there just singing away to that song. But I figured out a way to fit that in. I'm always massaging my lymphoma, doing that, rubbing the head and that guy. So they're probably thinking, that's that crazy guy. But I guess the key to this is the therapist. I mean, you've got to pay attention. They know. And probably some of the most important things that they know, when you talk to them, they've seen so many patients. They've dealt with so many different types. We're all different as individuals. We battle this disease differently. We all do. We're all set up different. But they have so many, well, I had a patient that happened to. Here's what they did. It may work, it may not, but you got to try it. You've got to try it. That's the key to all of this, If this doesn't taste good to you, I'll go back. So I had my tonsils removed, and they were all messed up. He dug them out. Yeah, he even messed me up in there. Mean guy. But I wouldn't change that head coach any day. He's good. So I lost my train of thought. Anyhow, he took my tonsils out. So everybody's like, well, you got to eat cold. You're getting radiation in there. You had your tonsils out. Ice cream's good for you. You got to eat cold. It was a complete opposite for me. Cold drove me nuts. It hurt and everything else. I went with warm food. Warm to hot helped me. Just because they suggest it doesn't mean it's going to work. So try the opposite. I couldn't eat chocolate. I love chocolate. But you know what I could eat? Vanilla. I couldn't stand vanilla before. I was always a chocolate guy. So the key is figure out what works best for you. You can't just stop and give up. You got to listen to your therapist. Even though that doctor, he's the head coach and everything, these are the ones that keep you in the game of life. I really believe that. He puts the game plan together. Dr. Jensen tells you how we're going to attack it. And then you got the team mom. I don't know what she did. She kept running me through tests. She wanted to make sure I was okay, which was good. You need that person. I say that lightly, but I mean you need her. So that's kind of where I'm at in life. You know, I hope at 20 years from now, I think you said 2003, Hannah. 20 years from now, I hope I have her energy. You know? So, thank you. You're welcome.
Wow. Amazing stories and, you know, such a motivation to all of us here. So I'm going to go ahead and see if we have questions.
There we go. All right, we already have some questions online from our remote group. So would yoga be helpful for lymphedema and range of motion and balance issues for head and neck cancer survivors?
Am I? I'm okay. Yes, absolutely. I'm not sure exactly what kind of long-term, I'm sure there's studies out there to support that, but I absolutely believe in that kind of calming breathing and that gentle stretch can absolutely be beneficial to survivors. But and the balance and things like that, absolutely.
There's
Right.
actually quite a few studies
Thank you.
showing the benefits of yoga for a lot of the long-term side effects for head and neck cancer patients. So absolutely beneficial.
Wonderful. And then can you talk more about trismus therapy and the different devices?
That's you.
Yes. So yeah, as we talked about or have mentioned today, trismus can often be a really kind of debilitating effect of often radiation, sometimes in surgery as well. And I have patients who, you know, when they have trismus, it can really impact things like social eating, or, you know, kind of being able to eat in front of other people in public. In terms of devices specifically, there's several different things out on the market. Therabite's a popular one. There's the Aura Stretch. There's a few others. There's even kind of more homemade devices like the tongue depressor unit that I showed on the screen. I've had patients who've brought in a cork, like a wine cork that they've been using to progressively open their jaw. And I would say to that while device selection is important, it's how you apply and use that device that's really key. Often these companies will have kind of in the box like a prescription of 5 sets of 5 or whatever. You really need to understand the principles of exercise physiology and apply that to what you're doing ideally with your therapist, and really personalize that therapy to you, because 5 sets of 5 might help for one person, but really may not help in your specific case. So that personalization is really important. Devices are one thing, but really how you apply it, it's not a recipe or a cookbook approach, is another.
Yes.
Yeah. Thanks for the talk. I just wanted to add to that starting the trismus therapies before fibrosis is the best means. So that means when restriction is developing, exercising and devices should be considered. And the active therapy devices are shown to be more effective than the passive, which is the cork and the homemade devices. So one of the problems is once fibrosis is established, it's a tougher and longer term haul and may not be very predictably reversible.
Right.
Yeah, I want to say that about everything. Like, one thing I knew when I was leaving, one of the things I knew was that my whole neck and back were going to be all fibrotic. And I knew that my jaw would be fibrotic too. And so I went to massage therapy like 3 times a week when I first started out, because I was so scared that I would be just a big mass of muscle all connected, which I kind of am. But and they would massage my jaw and then massage my back and my shoulders 3 times a week. And that's kind of a lot to take off of work, but I just did it anyways. And for years, I've had 20 years of massage therapy, I would say. And that's kind of extensive, but I got away from Blue Cross to Blue Shield to code it right so that I could get it all covered by insurance. And I've done it for 20 years. And there's been years I've gone off, but I have known, like, okay, maybe there's 2 or 3 years I've gone off actually. But I have always had massage therapy my whole life. There's been 2 years is the longest I've ever gone off. It's just been a way of life for me.
Hannah mentioned the tricks about getting coverage for insurance. One
Oh my God,
barrier.
yes. I've fought so much. I've learned so much. And also, just wait till you go to disability. You should have a whole session on thinking about disability. Like if you quit working, you should really think about disability before that ever happens. Because I'm fighting with them, but I think I'm about to get it. But man, when the doctor expert comes in and talks about how you get sick from disability, cancer after you had cancer, then you're not better. He's like, I thought you got better. I'm like, wait, I did, but I'm getting better from the radiation. And he's like, and they asked the expert, they're like, well, Hannah's saying that she's sick from the radiation treatment. Is this true? Well, yeah, she got better, but it's complicated. The doctor's favorite word was, it's complicated. And he's the expert. But I think I'm going to get it, so. It just took a long, long time. Ask me later. Okay.
And obtaining those active assistive
later. When do we
devices are
continue?
very
Okay.
challenging. Absolutely. So does anyone that prescribes...
People don't know that you have to get better from the treatment later.
Do any of you that prescribe Therabyte, for example, can you walk us through how to get coverage for that? Because I find that as a major struggle for my patients.
That is a struggle. And I, again, sometimes then have to kind of pivot to an alternate kind of homemade device, which is kind of a pain because you have to kind of remake it over and over again. So sometimes that's kind of your only option, or really just being creative with some of the tools that you already have to still get that kind of passive and active range of motion, depending on what kind of modality you're treating. Again, you want to make sure whatever you make is doing what you intend it to do. But yeah, that has been a challenge for sure.
You know, it's interesting. Patients don't realize that they're getting trismus because it's so gradual. So really, it's often the physician that picks it up when you're trying to examine their mouth and palpate their base of tongue, and you realize, and you ask them, and they have never complained about it. But I think the homemade device for trismus, really with the tongue blades or popsicle sticks and stacking them up, really works well. And for patients, they really see the improvement because you add one more tongue blade and then you add another, and it gives, you have a goal to work with. So that's a really cheap, good alternative. Because
It's hard if you stop eating, because I've never stopped swallowing and chewing and eating. And if you've stopped it, I think it's hard, right, to get it back?
Right, yeah. So sometimes that, stopping use, whether it's during radiation or after, which is why that kind of continued use it or lose it kind of concept comes about. I also wanted to mention too with trismus, it's not even just necessarily the degree of mouth opening, it's also just the symptoms associated with it too, that feeling of tightness and discomfort and pain. Sometimes the millimeters can be within normal limits, but they're still having some discomfort from it, and that's still treatable, something that we can address.
So I honestly don't know anything about trismus except what I've heard today. So can you tell us, like, when we talk about when we know we're having, when we recognize that we were having a situation that could be cancer, trismus, tell us, it's me, and I want to know, how do I know if I have a sign that I could potentially have that? Yeah. Is there something that you can tell us that we can actually, like a self-exam or something that does something like that?
Yeah, so like I said, one thing I do for opening is kind of like the 3-finger test. So stacking 3 fingers, that should be about normal if you can get 3 fingers in your mouth. Again, but like I said, that's just a very quick, gross estimate of degree of movement. But again, if you're noticing like yawning is kind of a spasm or a tightness when you go to yawn, or opening your mouth to eat a sandwich and you notice that you're kind of eliminating foods because just not necessarily swallowing them, but the act of getting it into your mouth is more difficult. Or fatigue with chewing. So chewing makes, your muscles get tired when you chew. Some of that tightness that you can feel, sometimes gets chalked up to, oh, you grind your teeth at night. Well, maybe it's actually more of a trismus-related issue. In terms of self-exam, again, like I said, that 3-finger test is the one I like to use the most. But I do also put my fingers in people's mouths a lot and kind of feel around back there too, to just kind of feel that firmness of those muscles of mastication.
I always thought it would be more like TMJ, like if you think your jaw hurts, but that could potentially be trismus if you're a radiation patient.
I feel like it's like achy right here, and it feels like it's tired. It's like achy right here, and you can push right in here. And it's like it is achy, and it just radiates up to your head.
Well, because I get massages as well, and I get them.
Yeah, like right. Yeah. It could be mistaken for TMJ. I feel like, well, I don't know, for mine.
And I do a lot of, like I said, intraoral work as well, not just on the outside, but on the inside too. And I try to kind of teach patients how to do that on their own at home as well.
Great, thank you. I have a question for Mark. I really appreciated your analogy of a game, and a team. And I'd like to know, did you have to advocate for yourself to get these members on your team? How much work did you have to do personally for that?
You're talking about the athletic trainers and all that?
All of them, yeah.
Yeah.
Obviously, Michael Moore, he came in probably without
No, when I was diagnosed, I went in on a Sunday to the ER. I wasn't feeling good and all this. They done an X-ray or a CAT scan. They were like, "Hey, we got to send you to an ENT." So the next day, that was Monday, went to the ENT, and the doctor said, "Oh, this is past me." He said, "I'm either going to have to send you or refer you to Cleveland Clinic, Pittsburgh, or I know a guy in Indy." And I'm thinking, let's go Indy. I didn't know he was going to kick my butt, but no. These people they're here for us. I mean, they really are. I don't think they could do it otherwise. Everyone I've dealt with, they care about the people. It wasn't too hard to pick them up on the team. They were ready to volunteer. So.
Well, I just have to speak on this because I wanted to say this in general. But for me, I'm a researcher, if you couldn't tell yet, and I'm an academic. And for me, I have to pick my team. Like if you're a cancer survivor, you have to pick the best in hospital, okay? Like in-network thing. I like to have all my doctors in the same place because it's so hard to put information from one place to another. And I was in the old days where you had to bring your scans in to the doctor and show them because they didn't have the internet yet, right? Where you could just transfer real easy. And so for me in Arizona when I lived there, it was Honor Health. And so all my thing went through Honor Health, all my doctors. And then I had to research in the system to find out who's the best neurologist, who's the best cardiologist, who's the best, whatever. And so for me here, it's IU. So within IU, who's the best cardio-oncologist, who's the best neuro-oncologist, who's the best psychiatrist. And so I do that. So I research my doctors. And my doctors say, I never had anyone research my background before and then find me. So I have a cardio-oncologist and I have a neuro-oncologist. And then I found my friend here. I was like, I researched you first, so. It's a little stalkerish, but you get the best treatment. Because I don't have time to find a bad doctor and then I'm spending months trying to find somebody good. Because I might die by then. I'm like, I can't have it. I just can't.
I agree with what Hannah's saying, but also I think you have to have a personal feeling. Something's got to click there, right?
Yeah.
So you may have the best here.
True.
I'm going to go back to my high school days. We had a teacher by the name of Mr. Toth. The guy was a genius. I mean, he was. He was so smart that he couldn't teach me. You know what I'm saying? He was way above me.
True.
Somehow you've got to be able to relate, And I would put my coach and me probably on the same wavelength of the brain, I'm going to jab you all day. You got me up here, so your fault.
That's true. Good point.
One of the long-term side effects, or sometimes short-term really, we've not talked about is hearing loss from the cisplatin. That hasn't come up, and I, just wanted to bring that up because, again, that's something, talking about caretakers, they come and, complain about it more than the patient. So again, something just to watch for. And
I'm going to use that on my wife now. She'll be talking to tell me to use them. I can't hear you.
Yeah, I think that's so important because we already have the risk of isolation because of the swallowing problems, speech changes, changes in our appearance, and then also maybe a hearing loss. So all of those factors we know can cause problems later in life with our cognitive function if we're isolated, and obviously the mental health concerns with that. So thank you for bringing that up. What about a patient navigator? Has anyone on the panel as survivors worked with one, or Julia and Cherie-Ann, do you have patient navigators in your clinical practice?
We got Marika. Huh?
Yep.
Yeah, I think that's key too, because when we need something, we need something. So a lot of times we can't get in touch with the right person or go through the right alley. So I knew all the time, and in fact, I called her Squeaky Will. Squeaky Will. Yeah, I can't say that. You need to help me. But anyhow, call her, and she would go the right way, and she would make it happen. Now, if we tried to get through to that doctor or wherever, didn't happen. But Marika, that works for Dr. Moore, she would make it happen.
That's good.
Yeah.
Yeah, I think the patient navigator definitely helps because it's hard sometimes to get in touch, with people through the clinic, and so having that one name and phone number to go to, who knows the right people, is important.
And they would call you back.
Yeah.
And having that navigator specific to head and neck or to the head and neck clinic, I think is very important too.
Perfect.
And I learned the hard way that you need to be an advocate for yourself. I learned the hard way not to confuse niceness with competence. I had a very dedicated physician early in my care. They were so nice, but they had very little experience, and I was too polite and too shy to ask them, tell me, how many cases like me did you do? I did it a day before the critical surgery, and was told only 2 cases, and it was too late to change it. And what they told me, you see one, you teach one, you do one. That's the motto of many physician surgeons. I learned that the truth is, you see 1,000, you do 200, and you teach and you do, but not before that. There are many studies, one published a month ago, that show the best results were done by physicians who had at least 5 cases a year. Laryngectomy, I'm talking. And the best, even the best one, were those who did more than 10. So for now, I overcame my inhibition, and I ask any doctor how familiar are with this issue, whether it's kidney or liver or neuro, and most of them are honest and tell, and I think it's okay to look for somebody who's better, because you're fighting for your life, and many of those situations are the best chances are the first time, and you want it to be done by the right person.
Thank you for that comment, Dr. Brook. I agree. I think being an advocate for yourself, whether it's in asking the questions of your surgeon or your treatment team, or asking for referrals, making phone calls yourselves when you have concerns and need to schedule things and you're not hearing back from your institution?
There's one word that can summarize it. It's in Yiddish. You'd say you need chutzpah. Chutzpah.
Does anyone else have any other questions for our panelists? Yes.
Sorry, I made you run all the way over here. I'm a nurse practitioner at a university hospital with head and neck. And things I'm constantly thinking about, looking at long-term side effects, when we see a patient come in with new cancer and we're talking about surgery and the function changes, people walk out of those appointments and their brain is just reeling with all this information, right? So you have this new information that you're getting with surgery, with how that's going to change your function and things like that, that there's really not, I don't think you could really be prepared for the surgery and the change of function, but we do our best to kind of prepare you for that. But there's also not a lot of discussion of the long-term side effects and things that you're going to be having to do for a lifetime. And so I'm always thinking, what's the best way? And this is a question for our cancer survivors is, how do we give that information to you? Is that kind of something that we need to do over time? It's also kind of a time constraint sometimes in clinic, but what's the best way that we can give you that information that you're going to be able to take away just the new information about an upcoming surgery when it's brand new, and then also taking on all the information that we want to be able to give you about the long-term side effects that you may experience as well. So what's the best way for us to give you that information without completely overwhelming you?
You want to take that question?
Well, to me, the Head and Neck Cancer Alliance here, stuff like that's probably ought to be, and I'm not saying it isn't because I'm kind of new to this, stuff like that and information, I'd post it on the website. What should we look for in a year from now? What should we look for? Because I'm finding out new stuff today that I had no idea about, which is kind of scary. I'm not that researcher like Hannah is. And they're all out there. I'm just glad to get up every morning and be breathing. I'm happy with life, I'll take on whatever's in front of me that hits me next. But listening to some of this today, I'd like to know that information. Now, do we want all this emailed to us all the time or whatever? But I would post something on a website or on the web, and I'm not, maybe it is. Is it posted on the website, stuff like this? Information? Some of it is.
I guess a lot of what we're learning today is how better to make it digestible.
Yeah. So, what should we look for in a year from now? Understanding, we get it. It could happen in 6 months from now, or it could happen 3 years from now, just because we're past that point. And we all get that, I think, because I never thought I'd get cancer either, But I think that'd be one way to get it out to us.
Well, I think, when you first get cancer, I don't know, this is 20 years ago for me, so, but when you first get it, you get the big packet, in the very beginning, and you're all overwhelmed and stuff, but you read everything because you're so scared, you read that big packet, and it's and then, after you get, you get radiation, and then after you get radiation, you might be a little tired, and then at the end you should say, and in a year, you might have to meet with a speech therapist. That's what I would put at the end. And then in a year, you meet with a speech therapist, and you might have to meet with, and then I would add, and then you might meet with a speech therapist for 2 years and 3 years, and you just add that at the end. And then I think that would be great. Just add it in there, because you're going to read all that anyways. I didn't start being a researcher until I actually had the secondary problem 17 years later. When I had a job, I didn't read anything, okay? When I had a job and I got sick those 6 months, I read nothing. I just got better, because I lost 80 pounds, so I didn't do anything. I just got better in those 6 months. I didn't become a researcher until I was like, I'm not gonna have a job, I'm just gonna be sick now and take care of my carotids, because I had nothing else to do. So I might as well research. But just put it in that packet, because they're gonna read everything in that packet. Believe me, you will read everything in that packet. Chemo, all that.
And I think as a provider, I feel like we, in kind of pre-radiation counseling or pre-surgery counseling, you go through a lot of things, And then it's not like until it becomes salient or relevant is when it's like, oh, yeah, we did talk about that, or we need to go over that again because we glossed over it or we mentioned it, but now it's becoming much more prevalent to me. And so I think the concept of arming with information from the beginning, but knowing that, okay, this all may not be relevant yet, but here's your resource and things to look out for, so that when it does become relevant, here's where you can find more information or advocate for yourself.
My problem with that is I attack one thing at a time. You tell me this, we're gonna have surgery, I attack that. And then once I'm done with that, I'm on to the next thing. Once I start reading like this, my mind goes, you know, I just think it's overload. That's right, it's not relevant yet, and we get so overloaded. I mean, he walked in the room and I don't even think he introduced himself, and he told me, he said, look, you got cancer, we got to come up with a plan. I'm Dr. Moore, by the way. I'm a straight shooter. It kind of went down that way, and I'm good with that. I'm good with the guy, but I don't like being overwhelmed, overloaded, whatever. I just, I don't know. That's me.
Multiple ways.
Yep, everybody's different. Yep.
And maybe, a good time to give people that information is when they are told they're disease-free, right? At the end of treatment, you get your post-treatment PET 3 months later, but that's the time, to, like, you're free of disease, but remember that there are delayed, and remind them at that point to keep doing their exercises twice a day. So I tell them to make it a way of life, really.
Yep.
And I think, too, I was going to add one more thing onto that. With those kind of surveillance visits, screening for kind of these other things that pop up, I think, I would say anecdotally, head and neck survivors are chronic underreporters of symptoms as they kind of move into surveillance. And so some of these subtle things may not be captured kind of in that just routine, how are you eating? And the patient says, great. And come to find out they chew meat and taste the flavor and spit it out. And that they think that, that to them is eating meat. And that's not, they don't swallow meat. And when you kind of get to the heart of it, that quick 15-minute office visit may not get into those things. And so I think just the concept of routine screening and things like that to kind of keep the potential need for these supportive care services on the front and center. So that way even, patients can report these things, but we're capturing it too without necessarily having to rely on self-reporting. So.
We got a lot of questions that came up all of a sudden. Yes, I've got a list here. So one thing I just wanted to add to that is there are work on cancer roadmaps. So you can ask for or create a cancer care roadmap that goes from treatment and then beyond. So those are other ways to condense the information. All right, I'm going to start here with Jessica. We've got an online question. Chris here, I think, and we've got a few. So.
Mine'll be quick. I just wanted to, I agree with what Mark said. I needed to just kind of take one thing at a time. So it was, surgery and then treatment plan and then down the road, just getting better. Just that was what I wanted to work on. And then like down the road, it's the other things. So I don't know that telling someone at the beginning that they're going to have to do all that is good.
I kind of like what Dr. Nathan said. Once we've been given that clear, because that would make me feel better and I could read it better then. But once I'm into that game, my first half game plan is attack this. My second half is going to be this. I got to take care of the first half first before I move to the second half. So that's just my thinking.
A couple ideas that we've come up with back here. Each person has their own time that they want to hear about these things. If providers had a survivor that they could rely upon and say, hey, Julia had just asked me this question. I think you'd be better able to handle it for her because you've been there. Those kinds of things. Also, you'll hear a little later about Inspire, the forum for discussion, as well as peer-to-peer opportunities that come from the Head and Neck Cancer Alliance.
Yes, thank you very much for mentioning that. While I walk over to hear this question, online, someone had asked if anyone received a survivorship care plan in their treatment.
I think it's a requirement now, right, for So to get a survivorship care plan, to get accredited. So.
Adding to the peer-to-peer comment, I think if you can find a support group specifically for head and neck cancer, which is a challenge because far and few between, or it seems like I was in one 17 years ago for several years, but you have people that are further down the road and can share what they've been through. And you know, when you're with there for a while, then you see new people coming in, and it fulfills you in a way to kind of help them down the road too. You know, usually the main point people tried to make in our team was get the feeding tube, but it's hard to find. I mean, there's regular cancer support groups, but talking breast cancer or other kinds of cancer really can't relate to the complications of head and neck cancer. So if you can find that or someone else or two that have gone through it, it can be a lot of help.
Well, I think that's why this group, or this meeting here in person is so important.
Yeah.
I've talked to several people so far, so it's great to meet in person.
I was just going to comment that I think also the peer-to-peer and Inspire is a really good solution, only because when I first finished treatment, I rang the bell and thought I was done. Quite honestly, I'd had no clue that radiation was the gift that keeps on giving and that the next 2 weeks would be the worst. So I thought I was done.
Exactly.
I would like to have a timeline by which I can look at it from the beginning and say, hey, you know, the first plan would be you're going to go through this treatment to get through treatment. And then after that, these are the things that you should consider. So therefore, it's not a shocker about you ring the bell and all of a sudden now there's this whole plan. I'd like to see it a time frame, obviously stating that it's different for all people, but that at least you know this is probably things you're going to have to look into afterwards, but it's not the thing to focus on right now.
I'd like to know, I'd rather know about something that could happen. If it doesn't happen, great, but if it, at least we know that it could. Yeah.
Yeah.
And I just had a comment about the survivorship care plans. I know for a while there was a strong push to have that as part of an accredited cancer center, and I think that still exists with many of the other cancer types, but I think it's less of a national push as it used to be, and so I encourage you to ask for one, and chances are they're making them for other forms of cancer in their institution and can be adapted, and there are tools like AH&S, if they are unfamiliar with that, that give templates, so you can also help educate your treatment team if you do want one. Any other questions for the panel? Or any other comments that the panel would like to make?
No, I think it's been a great session. We've all learned so much from each other. So thank you.